which we are not subjecting to the same standards. When these facilities close, and they will, women will lose access to their trusted provider. These closed facilities cannot offer any other services that they may have been providing. And we know that in Texas, sometimes these facilities are shared facilities where family planning services are also provided. What is required of reproductive health care centers today? Today in the United States, reproductive health care services are among the safest and most commonly sought forms of care in the United States. Placing unreasonable requirements on health care centers that provide safe, legal abortion today is uncalled for, and again, not a hint of evidence has been offered as to why it's needed. And we know why. Governor Dewhurst's tweet told us why. It is because the real aim of this bill is not to make women safer, but is to force the closure of multiple facilities across the state of Texas without a single care or concern for the women whose lives will be impacted by that decision. Not a single care or concern. Because our leadership has demonstrated that it is prioritizing its own political possibilities over potential and devastating consequences for individual women. Let's talk about the parts of the bill that are medically unnecessary. First of all, I think each of us would agree that as patients, we trust our doctors, not the government, to determine what medical equipment and what size room is necessary to provide us with good care. It is medically unnecessary to require health centers to build a hospital-grade operating room for an abortion procedure when one is not required for this type of procedure. And in fact, we know there are many outpatient clinical procedures that are more invasive, have higher incidences of problems that today are allowed to take place in clinical settings such as a doctor's office without the standards that are being required in this bill. Texas, of course, as I said a moment ago, already requires that abortions performed after 16 weeks be performed at ambulatory surgical centers. This provision, the provision in these bills, goes further by requiring that all health centers that provide abortions comply with regulations that are equivalent to those governing places where surgery takes place. The vast majority of abortions, however, are outpatient procedures that can be performed in a health center, making those requirements inappropriate, unnecessary, and not at all about the health of women. I want to read into the record written testimony that we were provided by a variety of groups on the measures that are before us today. This from the Texas Medical Association. It was addressed to the House Committee on State Affairs on House Bills 16 and 60 by Representative Jody Laubenberg, and it's dated June the 20th, 2013. The Texas Medical Association is a private, voluntary, nonprofit association of more than 47,000 member physicians and medical students. TMA was funded in 1853 to serve the people of Texas in matters of medical care, prevention, and cure of disease, and improvement of public health. Today, our maxim continues in the same direction: physicians caring for Texans. TMA's diverse physician members practice in all fields of medical specialization. Our member physicians fall on both sides of any debate on abortion. Our concerns with House Bills 13 and 60 are not based on any position on abortion. Rather, our concerns are with legislative intrusion into the patient-physician relationship and the details of the practice of medicine, and with a legislatively created standard of care. Example of concerns with these proposed bills are House Bill 60, Section 3, Subchapter D, directs physicians to take specific action related to the prescription of an abortion-inducing drug approved by the U.S. Food and Drug Administration for use by women who seek an abortion. The bill prescribes details in the practice of medicine, such as requirements for the examination, patient-physician communications, and protocols. As previously outlined in our written statement on Senate Bill 97 in the 83rd Texas Legislature, TMA is concerned this legislation sets a dangerous precedent of the legislature prescribing the details of the practice of medicine. The medical community, based on science, must make these determinations, not the legislature. Sections 171.0031 and 171.063C in HB 60 would require a physician or other healthcare personnel to be available by phone 24 hours a day indefinitely. Although the intent of these provisions may be to allow the patient access to the provider for assistance with complications, as written, they are overly broad and could require 24/7 access for years. Furthermore, these sections are vague in that they appear to require access to medical records 24 hours a day, which is an overly broad and unprecedented requirement. House Bill 16, Section 2, Subchapter C, and House Bill 60, Section 3, Subchapter C, include a definition of profound and irremediable congenital anomaly based on the amount of time a physician reasonably believes the infant would survive after birth. The definition places that time at minutes to hours, which TMA opposes because it is arbitrary and would be impossible for a physician to predict. The bill may seek to allow an exception for conditions in which death after birth would be imminent, and in that regard, use of the word imminent would be more appropriate than minutes to hours. Additionally, this proposed definition does not take into account fetal trauma, which in severe situations could result in imminent death after birth. The following definition for severe fetal abnormality currently exists in Section 285.202 Health and Safety Code and may be an appropriate definition to replace the proposed definition for profound and irremediable congenital anomaly to severe fetal abnormality, meaning a life-threatening physical condition that in reasonable medical judgment, regardless of the provision of life-saving medical treatment, is incompatible with life outside the womb. The patient-physician relationship is one of mutuality and trust. Patients must be able to trust that their physicians are always acting in each patient's individual best interests and must be assured of candid communication with their physicians so they may effectively evaluate their medical care options. TMA strongly opposes any legislation that interferes in this relationship. TMA appreciates the opportunity to provide you our concerns regarding HBs 16 and 60 and urges you to take these comments into serious consideration. We are happy to provide any additional information or assistance you may request, and it is signed by Stephen Brotherton, MD, the President of TMA. We also had written testimony provided to the Health and Human Services Committee by Robin Wallace, MD, MAS, who is a Leadership Training Academy Fellow with Physicians for Reproductive Health. She testified before the Texas Senate Committee on Health and Human Services on Senate Bill 537 during the regular session on March 19, 2013, and she provided this written testimony, which I think is compelling. Physicians for Reproductive Health is a doctor-led national advocacy organization that uses evidence-based medicine to promote sound reproductive health policies. We work to make quality reproductive health services an integral part of women's health care. Physicians for Reproductive Health opposes Senate Bill 537, which would impose burdensome, expensive, and unnecessary requirements on facilities providing surgical abortions in Texas, causing many to shut down. Though this bill purports to improve patient safety, it would in fact harm women by reducing access to safe, timely abortion services. I am a board-certified family medicine doctor licensed to practice medicine in Texas. I received my medical degree from the University of North Carolina in Chapel Hill. I completed my postgraduate training at the Santa Rosa Family Medicine Residency, an affiliate of the University of California, San Francisco. I also completed a fellowship in primary care research and family planning at UCSF as one of a select number of family physicians who have participated in this specialty training. I currently live and practice in the Dallas-Fort Worth area. I am pleased to submit this testimony in opposition to SB 537 on behalf of Physicians for Reproductive Health. SB 537 is harmful to women. As a physician who takes care of women every single day, I cannot stress enough how dangerous these laws are to the health and well-being of my patients. Women need timely access to safe abortion care. SB 537 imposes medically unnecessary standards on abortion facilities. SB 537 would require abortion facilities to become ambulatory surgical centers, ACSs, which are the setting for complicated and invasive surgical procedures. Abortion, especially early abortion in the first 12 weeks, is a safe medical procedure with inherently low risk in outpatient settings without hospital-like facilities. Serious complications arising from surgical abortions at any gestational age are uncommon. By comparison, pregnancy and childbirth are significantly more dangerous to women than abortion. For example, CDC data indicates that the pregnancy-related mortality ratio in the United States is 15.2 deaths per 100,000 live births, compared to 0.64 deaths per 100,000 legal abortions. And she provides a footnote for that from the CDC in a report that was compiled in 2011. The requirements imposed by this bill are simply medically unnecessary, unsupported by scientific evidence, and contrary to the standards of care. She goes on to say, I think of my patient Samantha, a mother of a 2-year-old son who was born 2 months early. Upon determining that she was pregnant again, Samantha was overwhelmed by the thought of another pregnancy with a potential risk of complication, and she decided to terminate that pregnancy. Luckily, Samantha lived within 15 miles of our outpatient clinic, which was easily accessible on a major city bus route. Samantha was able to have her abortion safely and timely in the first trimester. Another patient named Monica, a 23-year-old woman, presented to me at almost 12 weeks. She had a 3.5-month-old baby girl at home who was delivered by cesarean section. This patient did not realize she was pregnant earlier because she had not had a menstrual period since her delivery. We were able to provide her abortion procedure to her safely and quickly so that she could return home to care for her baby. A young mother does not have time to travel many miles or hours away. She needs to be able to get back to her infant and take care of herself and her family. My patients come from all walks of life, from every situation imaginable. One thing they have in common is that they seek abortion because they've weighed all the options and know in their hearts that this private decision is best for themselves and their families. They do not deserve the burden of a law that has no medical benefit or basis. If SB 537 becomes law, I fear for my patients like Samantha and Monica, who already face challenges receiving abortion care in Texas. The cost-prohibitive regulations associated with SB 537 would force safe, accessible abortion facilities to close while doing nothing to improve patient safety. SB 537 would deny women safe, needed medical care. SB 537 would create unreasonable obstacles for healthcare providers like myself who are committed to protecting the health of women by making these needed services available. Many health centers would close due to the inability to comply with the standards of an ASC. In turn, this would force women in Texas to travel out of state if they have the resources, or would deny them safe care altogether. I cared for a patient, Julia, a registered nurse with a young child at home. Julia was pregnant, and this was a very wanted pregnancy. She and her husband discovered through a routine 14-week ultrasound that she had a very high-risk pregnancy with a significant chance of stillbirth. They made the difficult decision to end the pregnancy. We were the closest provider to Julia, but still a 4-hour bus ride away. Due to current Texas state law, she had to make this trip twice, once for her required ultrasound and again after the mandatory 24-hour waiting period to have her procedure performed. Another patient of mine drove 5 hours by herself because there was no provider closer to her. Her pregnancy was diagnosed at 22 weeks with a lethal fetal anomaly. Continuing the pregnancy would mean waiting for the fetus to die in utero, during labor, or immediately after delivery. My patient and her husband made the heartbreaking decision to end the pregnancy. She had to stay alone at her hotel until her husband could follow 2 days later for the final day of her procedure. I provided care for her, and she did medically well, but she experienced financial hardship associated with traveling such a long distance to receive care. As a physician, I know that access to safe and legal abortion care is critical to the health of women. When abortion becomes less accessible, it becomes less safe. Medically unnecessary restrictions on abortion cause women to delay their care as they locate a provider, travel greater distances, or even seek services of an unlicensed provider all resulting in taking unnecessary risks with their health. While Texas women have the right to safe, legal abortion, in reality, there are already very few facilities in Texas to provide this essential care. In 2008, 92% of Texas counties had no abortion provider, and she cites for that a report prepared by the Alan Guttmacher Institute, State Facts About Abortion, available online and last accessed according to her footnote March 15, 2013. Decreasing the number of providers in Texas will have negative effects on women even beyond the immediate outcomes of their pregnancies. Recent research has shown that when a woman seeking an abortion is denied access to care, she is more likely in the future to become unemployed, live below the poverty line, and experience intimate partner violence. And she cites for that statement Green Foster reports on the socioeconomic consequences of abortion compared to unwanted birth. And she also cites K.S. Chibber, Receiving versus Being Denied an Abortion and Subsequent Experiences of Intimate Partner Violence, in support of her statement. If additional facilities are forced to close under the burden of SB 537, this would have a devastating impact on the health and well-being of Texas women and their families. Conclusion. SB 537 does nothing to improve patient safety. Rather, it would close the doors on many clinics that provide comprehensive, safe, legal, and compassionate care to women in Texas. On behalf of Physicians for Reproductive Health, I strongly urge the Senate Health and Human Services Committee to oppose SB 537 and protect Texas women's health. We also received this written testimony from the Texas Hospital Association regarding admitting privileges. And this was provided on June 20th, 2013. This was testimony given in opposition to Section 2 of House Bill 60, as filed by Representative Laubenberg, relating to the regulation of abortion procedures, providers, and facilities, and given to the House Committee on State Affairs, June 20th, 2013. The Texas Hospital Association, on behalf of its 450 member hospitals, offers the following statement in opposition to Section 2 of House Bill 60 as filed. Number one, hospitals should not be required to grant privileges to physicians who do not practice in the hospital. THA agrees that women should receive high-quality care and that physicians should be held accountable for acts that violate their license. However, a requirement that physicians who perform one particular outpatient procedure, abortion, be privileged at a hospital is not the appropriate way to accomplish these goals. A hospital's granting privileges to a physician serves to assure the hospital that the physician has the appropriate qualifications to provide services to patients in the hospital. Thousands of physicians operate clinics and provide services in those clinics, but do not have hospital admitting privileges. Requiring a hospital to grant admitting privileges to physicians who do not provide services inside the hospital is time-consuming and expensive for the hospital and does not serve the purpose for which privileges were intended. Rather, the Texas Medical Board is the appropriate agency to address whether physicians are delivering appropriate care to patients, as the TMB regulates all physicians. Hospitals should not be required to assume responsibility for the qualifications of physicians who do not practice in the hospital. Should a woman develop complications from an abortion or any other procedure performed outside the hospital and need emergency care, she should present to a hospital emergency department. Requiring that a doctor have privileges at a particular hospital does not guarantee that this physician will be at the hospital when the woman arrives. She will appropriately be treated by the physician staffing the emergency room when she presents there. If the emergency room physician needs to consult with the physician who performed the abortion, the treating physician can contact the doctor telephonically, which is often done in other emergency situations. Thus, THA respectfully requests that the language in proposed Section 171.0031, Section A1, be deleted, as the language in Section 171.0031, Section A2, is the best and most appropriate way to ensure that a woman who experiences complications from an abortion can get advice about and treatment of those complications. Section 171.0031A2 requires that the physician performing the abortion provide to the patient the following: a 24/7, 365-day a year line for her to be able to contact the physician or physician's office, the name and contact information of the hospital nearest to her home, as the woman will seek hospital services through the emergency department. Additionally, Section 245.023 of the Texas Health and Safety Code requires the Texas Department of State Health Services, the licensing agency for abortion facilities, to maintain a toll-free number through which individuals can learn, among other things, whether an administrative or civil penalty has been imposed against the facility or a physician who provides services at the facility, whether professional discipline has been imposed against a physician who provides services at the facility, and whether there are any criminal convictions of the facility or of a physician who provides services at the facility that is relevant to services provided at the facility. A copy of Section 245.023 and the implementing regulation are attached as Appendix A. They also provided a proposed amendment with alternative language. As an alternative to the deletion of Section 171.0031A1, THA requests that new subsection C be added to Section 171.0031 to clarify that hospitals are not required to consider or grant medical staff privileges to physicians who perform elective abortions. To begin the process of privileging, a physician submits an application to a hospital for membership on the medical staff and a request for clinical privileging. The hospital is required to review any application received and take action on it within specified timelines. Failure of the hospital to review the application or reject it without review could be grounds for a discrimination lawsuit against the hospital. To require hospitals to consider applications for medical staff membership and privileges from a physician to perform abortions will impose unnecessary administrative costs on hospitals and may subject hospitals to legal challenges if an application for membership and privileges is denied because a physician performs elective abortions. A copy of THA's recommended amendment to Section 171.0031 is attached. The attachment reads, Appendix A, Section 245.023, Public Information, Toll-free telephone number. A, the Department on request shall make the following information available to the public. 1, the status of the license of any abortion facility. 2, the date of the last inspection of the facility. Any violation discovered during that inspection that would pose a health risk to a patient at the facility. Any challenge raised by the facility to the allegation that there was a violation, and any corrective action that is acceptable to the department and that is being undertaken by the facility with respect to the violation.